A special thanks, of course, this morning to Dr. Bruce Levy, our visiting professor, for joining us from the Mayo Clinic. Dr. Levy truly has and continues to bring light and knowledge to hard questions in orthopedic surgery. Born and raised in Montreal, where he received his medical degree, Dr. Levy completed residency at the Mayo Clinic in Rochester, followed by an orthopedic sports medicine fellowship in the Minneapolis Sports Medicine Center. In a bit over the 20 years since completing fellowship in 1999, he has sustained a focused attention on the treatment of knee dislocation and multiligamentous knee injuries, and was the director of the Mayo Clinic Knee Dislocation Surgical Skills course we were just hearing about. His honors are many. I will point out he's principal investigator for both NIH and DoD multi-centered funded trials, as well as the sports medicine deputy editor for clinical orthopedics and related research, a frequent chair of symposia and committees for all of our major orthopedic societies, a consultant for the NBA, as well as team physician for the U.S. snowboard team. He is also a Rush fan, as well as having published over 250 articles. On Thursday night, he kindly joined us for a Spirited Journal Club, and I really look forward to hearing more from him today. So we'll go ahead with some intro music here for Dr. Levy as we let him set up his presentation on the Mayo Clinic experience with the multiligamentous injured and dislocated knee. Some working man from Rush. Thank you, Dr. Levy.
Where is it? Where is it? I can't hear
it. We can just keep it going.
So, Working Man is, there it is. There it is. So Working Man actually was the first song that hit in Ohio in the United States for Rush. It was sort of their entry into the US, and people really related to it, and their career just took off in the United States with that song. Just a little background.
That's great.
Ken knows that on my service, there's service guidelines. Most of my partners have like pages and pages of service guidelines, and my guideline only has one sentence: no rush, no scrub. If Rush isn't playing in the operating room, they're not allowed to scrub in on the case. Anyhow, listen, all kidding aside, it's just an absolutely fantastic honor to be with you guys. I'm so sorry that we couldn't be there in person. It would have been a fantastic couple of days. And Jackie could have taught me all her new tricks, so that would have been really neat. And to be the Beals Memorial Seminar speaker is just a phenomenal honor, listening about his life and his accomplishments and what he has meant to the community there and to the orthopedic department. And I'm thrilled that there's a family member that could be here in his honor. And so with that, I'll get started on the Mayo Clinic experience with the multi-ligament injured dislocated knee. So here are my disclosures, and they involve some of the research funding from outside sources, and as well, I'll bring your attention to this PCL guide system, which I will be referencing in my talk. And just so you know, Ken, Mayo owns my brain and my intellectual property. And even though they sell a gazillion of these things every year, my personal compensation last year, after over 10 years, finally hit over $500 in the year. I think I had $503 last year. So I'll give you a little reference.
Congratulations.
Thank you. So I had to tick the box, the 5,000 to 5,000 in my disclosures for the first time. So this case I'm going to show you, I'm going to kick off with this case. This is a case that there's so much to learn from, and it's really one of those unfortunate things that happened to a young person. Eventually had, what I would call a reasonable result, but there's a lot we can learn from this. So he's a 16-year-old. He's playing high school football. He's tackled. He has an obvious severe knee injury, and he presents to the local emergency room, and they see these X-rays. Now, if I was there, I would ask the residents or the fellows, well, what do you see? And this was read as an ACL avulsion because of this little fracture off the anterior aspect of the tibia. But the only way for this to happen is for the femur to literally roll off the front of the tibia and then snap back. So when you see an anterior rim fracture, that tells you there's something more ominous. Plus, the ACL attaches over here. It doesn't attach off the front of the tibia. So he's writhing in pain. They say that he's neurovascularly intact. Pay attention to this. Neurovascularly intact with 2+ pulses. Okay? Neurovascularly intact with 2+ pulses. So he's a tough kid. You know, he's captain of his football team. He's captain of his wrestling team. And he's not doing so good. And they're telling him, look, we're going to put you in a knee immobilizer and have the local orthopedist, you know, take care of it this week. And he's not doing well. And finally, something like 8 hours later, 6 or 8 hours later, they finally say, you know, we better get somebody to look at this because the leg doesn't look good. Vascular comes down, they get an angiogram, and he has a complete popliteal artery occlusion. Now, how is it possible, you say, that he had a palpable pulse? Well, he had a palpable pulse because of collateral flow. And it's been long recognized all the way back from the war days that you could have a palpable pulse distal to a major arterial lesion, in particular because of these collateral flow mechanisms. So he's transferred to our institution. It was, you know, one of those, you know, October days, and it was snowing, championship games, and they couldn't get a helicopter to bring him in. So they had to wait for a fixed wing aircraft. And he finally gets to the OR 9 hours later. He was in Aberdeen, South Dakota, where this happened. And why did it take so long? It took so long, number one, because of a delay in recognition. So here he comes in, 9 hours of warm ischemia, right? Not ideal. And here's the popliteal exposure. You could see that the vascular surgeons did a bypass graft, 4-compartment fasciotomies, and put him in a spanning fixator. And this is the back of his knee. Jackie, check this out. There's his sciatic nerve. Here's the tibial branch, and here's the common peroneal nerve that's tagged. Remember that they said he was neurovascularly intact, which obviously is impossible because he wouldn't be able to dorsiflex his foot. And if somebody had seen a knee injury and done a proper exam and saw a patient can't dorsiflex his foot, they would probably think, wow, we might have something a little more serious here. So here's his MRI. You can see that his ACL is torn off the tibia. Notice again where the ACL inserts, right? It doesn't insert off the front of the tibia. And he's got the PCL injury, and his lateral side, I mean, you could barely make anything out. There's popliteus, there's the lateral collateral ligament, obviously not looking so good. And so here he is 48 hours later. We take him back to wash out his compartments, and everything's dead. There's no sensation or motor function below the knee. So what are the options for this 16-year-old male now? Well, if you look at the increased energy expenditure of amputations, a below knee adds about 20 to 25%, and an above knee about 60 to 70%. So at 16, if you do an above knee amputation, you probably do just fine. But as he gets older, or God forbid, he develops any pulmonary compromise, it can be the difference of ambulating versus non-ambulating. So I thought, if we can get control of the soft tissues, regain motion, stabilize the knee, and then do a delayed below knee amputation, I felt that would give him the best possible function. Now, somebody my age, you know, I have to get back to work and support my family. I'd probably just have the AK, but a kid like this, you got time on your hands, so you can really consider limb salvage procedures. So here we are 4 months post-injury. And you can see our 12mm reamer heading right towards the vascular clip. So obviously heart rate goes up when you're doing this procedure. And here's his ACL and PCL. Notice the very high position of the PCL and low position of the ACL. And then in this particular case, we use the anatomic post-lateral corner reconstruction technique developed by my friend Rob Laprade. And here's what it looks like. This is for the ACL, the PCL. Here's our graphs. Now, pay attention to this. So this is drilling front to back on a tibia for the posterolateral corner tunnel. And you can see here, that's where the socket or the tunnel's made, right in line with the vascular clip. So you may not get it with your PCL tunnel, but you may get it with your popliteus tunnel. So anytime you're drilling front to back on a tibia, I would highly encourage you to use fluoroscopy to help with that part of the procedure. Here's what the graphs look like. Here's the LCL portion, the popliteus portion. Here we're just imbricating his capsule and then closing the IT band. And then 11 months later, we regained motion. We had to have the tumor guys do the baloney amputation because of all the previous fasciotomies and infections and everything else. Was a complex baloney amputation. And then here he is 2 months after the amputation, and thankfully he's got a stable knee, and thankfully he's got good motion. And then here he is wrestling for South Dakota. All he has is a pad. There's no brace. He's got a pad. And for those of you in the wrestling world, you probably recognize this guy because he was ranked 6th in the country in his weight class and had a very, very sweet college career. And now he's the spokesperson for Limb Lab, which is like a big prosthetic company. He's a physical therapist. So it's important to recognize that these are limb-threatening injuries. And people always ask me, like, do you need angios on everybody? Can you rely on physical exam alone? What about ankle brachial indices? Well, arterial injury can occur in up to 50% of these, so high risk. And arteriography is considered the gold standard with excellent sensitivity and specificity, but there is a 5 to 7% false positive rate. You got to go through the groin, so it's pretty invasive, and the risks are not benign. Duplex ultrasound is fast, it's non-invasive. The problem is it's technician dependent, and not everybody has like a 24-hour, ultrasound technician available with skills that can look for this. Now, the ABI, the arterial pressure index, was popularized by Mills, and it basically showed that if you have an ankle brachial index of greater or equal to 0.9, the odds of having a major arterial lesion are 0, 100% negative predictive value. Conversely, if you have an ABI less than 0.9, 70% of those had positive arteriograms. A lot of them were intimal flap tears, but nonetheless, it warrants further investigation. And then if you look at CT angiogram has been available a long time. It's underutilized. It's faster than conventional angiography. It's less invasive because you go through the antecubital fossa instead of the groin. It's 1/4 the radiation exposure and has outstanding sensitivity and specificity. So this is the algorithm that we talked about the other day, that we got vascular, ER, trauma, ortho, everybody to agree with. And this is for all high energy lower extremity trauma. So distal femur, tibial plateau, floating knees, knee dislocation. If we do ABIs, and if they're greater or equal to 0.9, we watch them carefully. And if they're less than 0.9, we do a CT angiogram. Now, does vascular injury affect outcomes? So this is a paper that you guys presented at Journal Club. And this is a 2-to-1 matched cohort on all my patients over 2 to 18 years. And we compared patients with and without vascular injury, but vascular injury that required a popliteal artery bypass graft, and we noted significantly lower functional outcomes. In fact, if you look at the mean IKDCs, the vascular group was in the toilet, and the non-vascular groups were in the mid-80s, which for multi-leg is, I think, pretty good. Similarly with the Lysholm scores, highly, highly significant. So this is a case I'll show you where vascular injury and bypass grafts, you really got to be careful. So he's a 17-year-old, and he's in St. Louis, Missouri, at a water slide park. And he's wearing those sticky water shoes so he doesn't slip around the water park when he's going from slide to slide. And he's going down the tube, the ones that are totally encased, and you lean back and you fly down at 60 miles an hour, but wasn't getting quite enough speed. So he decides that when he's in the tube, he's going to lean back a little further, and he leans back, his feet go up, the sticky water shoes catch on the tube, and he dislocates his knee. So he comes flying down this thing at 60 miles an hour, the dislocated knee, comes out of the thing, he's screaming in pain. This is in the ambulance with his dislocated knee. And in St. Louis, they do a CT angiogram. You can see he's got a complete artery occlusion. And they do emergency bypass grafting, fasciotomies, and a fixator, just like the other kid. And then a couple weeks later, they transfer him to me for definitive ligament surgery. And here's why I mentioned the other night how important it is to get MRI and know where that bypass graft is. Remember that a bypass graft is no longer an artery with fairly thick muscular walls. It's now a vein, which has thin, friable walls. And if you hit that thing, it's very, very tough. It's not easy to just put a stitch in it. And here is where it is, and that's where I'm going to be putting my PCL socket. So it's literally pasted up against the back of the tibia. So it's really important, I feel, to establish a posterior medial portal and get all the way down the PCL facet. So here's the mammillary body. So we're all the way dropping off. We're slowly, slowly clearing that down. My heart rate's pumping at whatever my max is, probably at this age about 105, but it's pumping pretty hard. And I get my guide in place. I'll show you more pictures of the guide in the PCL talk. And basically, in order to get the guide in, you have to get underneath the PCL facet. I've got my reamer in. I ream. I clear out the snowy, bony debris, and I'm looking at 9-0 suture. Jackie, I'll never know how I didn't hit that thing. I literally don't know. This case, I think I told you, I had the vascular fellow scrubbed in the OR. We had prepped him all the way up past his groin. We had the vascular pans, everything open on a separate table, ready to go. And I mean, you'll never get any closer than that, but I never want to see those sutures again, I can assure you. So then we did his ACL and his PCL standard. Notice a high position of the PCL, low position of the ACL. And then we did his posterolateral corner, and you can see these are anchors for his posterolateral capsular repair. And in this case, we did all inside ACL and PCL with cortical fixation, as we talked about the other day. And here you can see there's no tibiofemoral subluxation. And then here he is. This is just under a year from surgery. And, you know, this is why we do what we do. You know, you get kids like this, and they just make you look good. I mean, this is a kid that took out his artery, and here he is, and he's just, you know, it's kind of like I play golf once a year, and I hit one good drive. I want to keep coming back. It's kind of similar to that with these patients. There's a lot that don't do well. When you have a kid like this, you just think, my gosh, I got to keep doing this. So he returned to high levels of function, and you know, these younger patients are just incredibly motivated. Now let's talk about the nerve. So the nerve gets injured in about 10 to 40% of the time. And we looked up actually, this is Danny Whalen's study. So this is a really important study. So 26 patients out of 91 with peroneal nerve palsy. And what they found is there was an increased risk of nerve injury if you had a vascular injury. So if people know this and they see that football player kid in the ER and he's got no ability to dorsiflex, which obviously they missed that, they would have been thinking, wow, he's got a knee injury, can't move his foot. Like, this is probably more serious. They probably would have got vascular involved right away. So it's really important to understand the association between vascular and nerve. And then this is our study I was alluding to, 2 to 18-year follow-up. We basically did a matched cohort analysis on patients with peroneal nerve injury compared to patients without. And what's shocking about this one, this did not meet our hypothesis. At the end of the day, there was no difference in their final IKDC and LISM scores, which really surprised us. And if you look at the 27 patients carefully with peroneal nerve injury, if they had a partial palsy, 83% recovered anti-gravity dorsiflexion. But if they had a complete palsy, no matter what we did, sural nerve transfers, neurolysis, motor nerve transfers, it didn't matter what we did. Only 38% regained anti-gravity dorsiflexion. I think somebody might have their audio on. If everybody could just mute, that'd be great. So what do we do at Mayo when we have somebody that has a transected peroneal nerve, or they've got a massive zone of injury, like over 20 centimeters? We know that the sural nerve grafts don't really work well when they're very, very long. So our guys are like, okay, let's forget about the peroneal nerve. We're going to bypass the entire zone of injury, and we're going to go behind the fibula, find a motor branch of the tibial nerve, and they go into the tibialis anterior muscle and find a motor branch and connect the two. So it's called a direct motor nerve transfer. And these are the first 11 knee dislocations that our nerve team did this on, and only 4 out of the 11 regain anti-gravity dorsiflexion. And you say, well, that's not that good. It doesn't beat what we were doing before. But what we noticed is all the 4 were the ones that we got to within 3 months of the injury. And it makes sense, because if the tib ant is completely denervated and you get muscle atrophy and fatty infiltration, then trying to put a motor branch into that's probably not going to work. So we learned a lot through that process. So what's our approach now? Our approach is, if they're partial, we observe because over 80% regain dorsiflexion. If they're complete, it's a little more complicated and depends on several factors. Let's go through that. If they're transected, and we document this by either ultrasound or MRI or both, and we know they're transected, they'll do an immediate motor nerve transfer. If they're in continuity, then we observe, we do serial EMGs, and usually, unless the 3-month EMG shows nothing, they might do a nerve transfer, but most often they'll wait and do a delayed tib tendon transfer. Now, tib tendon transfers are awesome. So we typically do these around that 9 to 12 months, and especially if the muscle's denervated, when we can't transfer the motor branch. And here's a patient of mine. It's his left foot, okay? It's his left foot. So take a look at this. This is him walking with shoes. There's no way you could tell that he's got a nerve problem. Now, here he is walking barefoot. And what happens with barefoot is as the ankle comes up, the toes go down. So you can notice it if you pay attention. You can notice it that as the foot comes up, the toes curl down. So that's the one thing. But in regular shoes, you can't tell. So here's an 18-year-old who fell off a roof, had a knee dislocation, and he had a complete peroneal nerve palsy, transected on MRI and ultrasound. Okay, I'm going to repeat that: transected. So ACL, PCL, lateral side. Here's his LCL just kind of floating in the breeze. And here again is his LCL and his biceps, which belongs over here. So, I mean, this is just an absolute blowout. And so we did an ACL, PCL, lateral sided repair with reconstruction. And then our nerve team came in on the same setting. This is right around 10 days from injury. And here he is, if you can believe it. This is 9 months post-op with anti-gravity dorsiflexion. And I wish I had a video of him at 2 years. I can't track this kid down, but I'm sure it's going to be better. But look at that. Anti-gravity dorsiflexion. So here's his ACL, PCL repair and augmentation. So you can see the bio screws here. So we repaired everything and put a graft in over top. So let's talk briefly about external fixators for, you see these patients in the ER. When do you put a fixator on? We talked a little bit about this the other night. Our current indications are to protect vascular repair, the open knee dislocation that's going to go back and forth to the OR multiple times, and the patient that you just can't maintain tibial femoral reduction in a brace. They're so grossly unstable, and you don't want to leave them posteriorly subluxed. So if you get them in a brace or a fixator, make sure you get a lateral x-ray, obliques if you need to make sure there's no residual posterior subluxation. And then we did a match cohort on all our patients that had an X-fix compared to no X-fix, and we were surprised, no difference in final functional outcomes, but a much higher rate of arthrofibrosis. So obviously they're higher energy injuries, they're more unstable, and the range of motion was about 101 degrees versus 119 degrees without the fixator. So you pay a price, but they can functionally still do very well. Now let's talk about surgical timing. So there are reasons to delay surgery, okay? So the open knee dislocation, obviously you don't want to be putting in fresh grafts, whether auto or allo, into a potentially infected milieu. And also to protect vascular repair, we want to make sure that the vascular is working before we start manipulating the knee too much and hyperflexing and doing surgery. Obviously with unacceptable soft tissues that need to heal, and in the polytrauma head injured patient that just doesn't have the ability to rehab. So these are all the reasons we delay surgery. Now, if you look at systematic reviews looking at acute versus delayed surgery, and also looking at staging, we talked a little about staging the other day too. So this is Mark Miller's group, this was our group, and this is more recent, and they all basically show the same thing, that early surgery tends to have improved outcomes, but at an increased risk of arthrofibrosis. And the other thing we found is staging is okay. I typically try to do everything at once when I can, and we can talk and review that during the question and answer period, but staging is fine. Okay, now let's talk about repair versus reconstruction. This is a little dear to my heart. This is Jim Stannard's work on PLC repair versus recon, 2-year follow-up, non-randomized, Look at the failure, repair group 37% and recon group only 9%. And I mentioned the other day when I saw this data, I thought, who in God's name reports nearly 40% failure rate? Like, that's like awful. And my resident's like, well, what's your failure rate, Dr. Levy? I'm like, let's go look it up. Can't be that bad. And it was worse. So we had a 40% failure rate with repair alone and recon only 6%. So, I mean, these numbers are almost identical in two completely independent series. So at that point, I think a lot of people sort of stop doing repair alone. And really, we do repair and augment with the graft, but there are times that it'll still repair. So let's talk about these reconstruction techniques. So this is the Laprade Lars Engebretsen technique, anatomic socket placement and graft placement. It requires 2 independent grafts and the tibial tunnel, which remember I showed you was right near those vascular clips on that last case. And they had 54 patients and their failure rate was 7%. Now, our technique, we had 61 patients, anatomic sockets, 1 graft, does not require a tibial tunnel, same identical failure rate, 7%. And for those interested, we have these techniques all online in our arthroscopy techniques. And now, interestingly, there are some cases where I use the Laprade technique, like I showed you with that last kit. And these are in what I would call the worst of the worst of the worst. These are kids that you pick up their toe and they just drop into hyperextension, recurvatum, and varus, and they're just the whole popliteus sling, is gone, capsule's off. And in that case, I do think they need an isolated popliteus tendon graft. And of all the two-tailed popliteus tendon grafts, Standard has one, Finelli has one, and Rob's, I think Rob has the most biomechanical validation, so that's what I use. And even in those, which are the worst of the worst of the worst, of me doing Rob's technique, the failure rate was only 9%. So it's really an outstanding technique, and a lot of tribute to Rob's group for like 20 years of research on that. So in 2021, we now really think about it not repair versus reconstruction, but more repair and reconstruction. So here's an 18-year-old football player, repair and augmentation. So you can see there's his ACL and his lateral side. Now, this is a classic MRI. Remember I talked about yesterday how I think because there's like all this intrasubstance signal change. So it's a distally based avulsion, but look at the ligament through here. There's signal change through the whole ligament, especially proximally. So the damage is done, and then you go and you put this back over here, but over time, the interstitial fibers just continue to spread out. So I believe that's a main reason why they failed. And the other is, I think, because in those days we were staging, and as the knee is bending back and forth, it's kind of slipping around, putting too much tension on the collaterals. So for those 2 reasons, I think repair alone did not do well. So in this case, we did a BTB ACL autograft. And then for the lateral side, we repaired. So these are, distally based anchors and anchors for the meniscal capsular separation, posterolateral capsule here. And then we augmented with the graft. So you could see this is distal and proximal. And here's the native popliteus, and here's my grafted popliteus. I took a semi-T autograft. It loops under the fibula, then back over, and then back over. So here's the native LCL, and here's the reconned LCL, and then we just fix it with the screw. So he's got the anatomic reconstruction over top the repair. So we're using his own tissue to sort of augment the recon or augment the repair with recon, whichever way you want to look at it. And he was able to get back to playing football. He's wearing a big bulky brace. It's hard to wear that in wrestling, although it's allowed. And his first game, he had 4 tackles and did very well. And again, these younger patients. And then this was a case I used all autograft, and I do like to use autograft when I can. Now, I still repair in some cases. This is a very simple distally based avulsion of the LCL and the biceps. They call it the conjoined tendon, even though it's a tendon and a ligament, but they both insert on the fibula. So you can see the quality of the tissue is excellent, and I was easily able to reach the fibula in full extension. And so I've got locking whip stitches in the ligament, locking whip stitches in the biceps. I pull it down, I've got anchors, and I drill a little hole, and I pull them through the bony tunnel, and I get double fixation, and those patients have done very, very well. Now let's move on to the medial side. So this is another repair versus reconstruction by Jim Standard. Not as dramatic change with repair versus recon. The MCL, I think, has much better healing capability. So 20% failure rate in the repair, only 4% in the recon. And again, we sort of think of it now as repair and reconstruct, depending on the quality of the tissue. So this is a 35-year-old female that was in a motor vehicle collision. And here's her x-rays. And this is something I think, Ken, that we see all the time. The x-rays look essentially normal. If you really pay attention, you might say there's a little bit of widening here compared to the lateral side, and there may be a sliver of bone somewhere implying a cartilage lesion. And here's the MRI. So I wish I could pimp your residents and ask them, where are the meniscus? There's no meniscus. So is this congenital absence of the meniscus? I wish. Unfortunately, she flipped both meniscus to the back of her knee. So most meniscus flip to the front, these flip to the back on both sides. So not an easy situation. And then the medial side was unrecognizable. I mean, there's like fiber here, there's nothing. I mean, you got a couple fibers here, but the whole medial side was just a dust ball. And so here you could see the very subtle opening to valgus stress. I don't ever do it that much on a lateral side and stretch the nerve, but on the medial side, it's okay. And then here you could see the grade 3 posterior drawer. Huge posterior drawer. And so this one we did with a midline open arthrotomy to reach in and get those meniscus out of the back of the knee. And then I made a separate posterolateral incision. So this is all inside out. And we have a double row stacked vertical mattress configuration. And then because of the posteromedial corner, we repaired everything. And then I augmented with a two-tailed graft. So this is the superficial limb, the posterior oblique limb. There's the semimembranosus tendon. And then we do a big capsular reefing. So there's the limb, the POL, and the final construct. And then here's the final x-ray. So this is a whole bunch of suture anchors for the meniscal capsular separation on the medial side, which was done open through that big midline open approach. And then the rest is, this is a posteromedial capsule. We had actually the medial head of the gastroc was off too on that case. So anyway, big posteromedial corner injury. Then we came back 2 months later, couldn't believe it. The lateral meniscus was healing and everything looked really good. The medial meniscus, just remember, was done open. I mean, you can't even tell that there was a tear there. So I think the capacity to heal is quite good in these. And then here you can see the very high position of the PCL and low position of the ACL. So a little blurry picture, but you get the concepts. The PCL always has to be right up against the front and quite high. That's the error that people make. And then here she is with good motion, and normally medial-sided injuries in particular have higher rates of arthrofibrosis, but she actually regained good motion. We had very aggressive motion with her between the two stages. So for rehab protocols, this is sort of the classic rehab protocol by Greg Finelli and Edson, where they basically had full extension for 4 weeks and toe touch weight bearing for 6 weeks. Laprade, though, started doing more aggressive immediate range of motion and non-weight bearing for 6 weeks. So a little bit different, but still not loading the grafts, but certainly moving the knee much quicker. And we're involved now, and you guys are jumping on board to this multi-center Department of Defense funded trial. The main PI is out of Pittsburgh with the physical therapist Jim Ergang. And we're basically randomizing patients, a double-arm randomized trial with early versus delayed surgery and also early versus delayed rehab. So hopefully with larger numbers, we'll be able to answer some of these critical questions about what's best for patients. And this is an injury, unfortunately, that occurs in our military quite often. And so they have a keen interest in trying to figure this out. So this is a final case I'll show for this talk. This is a 26-year-old. He was in a motor vehicle collision in December 2018. And he had this spinal cord injury here with an incomplete T10 para, right femoral and tibial shaft fractures, and an open knee dislocation. from an impaled object, something from the car, like drove through the back of his knee and took out his artery. And so the vascular guys did a big open approach and bypassed him, fasciotomies, fixator, and then he had a T9 to T12 spinal fusion, and you could see the dislocation here. And then a week later, they rotted his femur and his tibia, and he was still so unstable that they put an external fixator back on, okay? And you can see all the clips here for the vascular. And then 4 weeks later, we took the fixator off. And then here's his metal suppressed MRI. You see, even with the fixator, it's pretty good quality nowadays, the MRI, compared to 15 years ago. Most of the external fixators are MR compatible. And so you can see the ACL and the PCL, you can hardly make them out. And here's the lateral side. You can see the popliteus is torn. And here you can barely make out the lateral collateral ligament, which is torn off of the femur. And MCL, cartilage, and meniscus, all his roots were okay, thankfully. And here is the vein graft location, okay, from the PCL socket. So notice on here, this is where we would do the PCL. So the sagittals can give you clues, but the axials really tell you how close the artery or the vein is. And remember that an artery, when you do an MRI, you're in full extension. So if the artery is, let's say, 5 or 10 millimeters away, when you flex the knee, it moves away probably 18 to 20 millimeters. Not a problem. But in a vein graft, where they've done a big posteromedial exposure, as you flex the knee, it may not move. It may stay right there. That's why you have to be so careful with these vein grafts. So when I first saw him, he was 7 weeks out in a wheelchair. His motion was 0 to 30. His ligament exam was extremely limited, but he was grossly unstable to varus. I mean, I could pull him all the way into Iowa with his varus stress. And he was just able to barely fire his quads. So here we are with a KD3L, T10 paraplegic, meniscus cartilage, okay, like what would you do? And my plan was like, look, he's not walking, he's in a wheelchair, like non-op, and give him a rehab and a brace, get his motion back and put him in a brace. So he comes back to me 3 months later and he says, Doc, I can't move in my house because my knee doesn't move. So it sticks out like a tree stump and I can't get in and around the hallways. And you've got to do something. I'm like, no problem. I'll scope your knee. I'll clean out the scar tissue. I'll get your motion back. So here he is. He's got under anesthesia 0 to about 40 degrees. Here's the patella, the trochlea. Look how thick that scar tissue is. And I got him to 120 safely. Remember, he had femoral tibial shaft fractures. I didn't want to go crazy, but we got him to 120. And so then he comes back and he says, I need to be in an exoskeleton. So being ignorant, I said, well, what's an exoskeleton? I'll show you a picture of it. And basically this is an exoskeleton. And so it's a machine that's battery powered and basically can help these paraplegics get up and walk. And I'll show you a little video after, but it's very important for lung function. It's all sensor based with things wrapping around the leg, so they can't wear a brace for the activity. And his knee is obviously grossly unstable without the brace. I'm like, now what? So I'm like, shoot. So now I've got to fix it. And so he's got his nails in place. And so here's my preoperative templating for his ACL, PCL lateral side. And so here's for his PCL, ACL, popliteus, LCL, LCL, ACL, PCL. And I'm thinking, if I do this carefully, I bet you if I just remove some of these locking screws, which the trauma team said it was okay, I'd be able to miss everything. It was just right. So I had all this stuff ready to take the nails out just in case, but I was hoping I could miss them and work around the nails. So here's the stress fuse. You could see here he's got a grade 2, 10 millimeter side to side difference. And then on his varus, he just opened right up. Again, I could have gone more, but I don't want to do anything more to him. And so here's the guide in place. And remember, I had room. This one had 7 millimeters between the vein graft. But again, you get all the way down the PCL facet, use the guide as a neurovascular protector. And then here's his femoral PCL socket. Notice right up against the articular cartilage. Here's his ACL socket right up against the back. And there's sort of panoramic of the ACL and PCL sockets on the femur. And I was able to just sneak past the nail. That's for his ACL. And so here's this ACL and PCL grafts in place. Again, notice the high and forward position of the PCL and the low position of the ACL. No PCL, no lateral wall impingement. And then for the posterolateral corner, I was able to sneak, not only go in front, but I was able to sneak behind the nail and able to get everything done. And this is a cortical button. Look at this, Jackie. It's over this big wad of HO. But it held fine, and I was not going to go take that out, I can assure you. And you can see here, no tibial femoral subluxation when we're done. And this is at 6 months post-op. This is day 1 with the exoskeleton. Watch this. Is this unbelievable? This is the first time he's standing since his injury. And I can tell you that psychologically, you can't believe how much it meant to this kid. So the take-home points, these are limb-threatening injuries. Each case is unique and needs an individualized approach. And you need a team, okay? You need trauma surgeons, you need nerve surgeons, you need a team. And for those that are interested, all of the surgical technique videos are online for PCL, post-medial corner, lateral side, for those that are interested. And then this is a little bit old now. It's 10 years old. It's hard to imagine. But this is our knee dislocation study group that put this together. And pretty much all the basic principles in this instructional course lecture still hold true today. I think the techniques have changed a little bit, but overall, in terms of management, this still works. And hopefully with sound basic principles, even in, a catastrophic injury like this kid, you can have good outcomes. That's the kid that, the wrestler kid. So with that, I thank you for your attention. And I can stop sharing now.
Thank you so much. That was excellent. I immediately loved your pictures of your preoperative plan for your tunnels. Is that something that you do routinely, or do the nails be in there, or things like that drive you?
Every single case gets templated out. And not only that, I put a list together in the OR. Actually, not a list. I do it with the whole team on the blackboard, and I list it out. And oftentimes somebody will say, well, what about this one? Oh, yeah, you're right. Okay, we got to do that first. And then as you go through that list, everybody in the room is making sure that we have the equipment for that. Okay, so when we're going to do our meniscal roots, when we're going to do our ACL, when we're going to do our transplants, when we're going to do the tibial socket, like what's the order of everything? And so everybody knows the steps. And if everybody knows the steps and you have all the equipment in the room, then it's just execution. And execution is tough enough. So you don't want to be in a situation where you haven't planned it out well and you're like in the middle of surgery, like, should I be doing that first or that first? No, if I do that for if you haven't thought that through, you could be spending a half an hour. And if you get it wrong, now you've just wasted time. So I think when you're doing big cases like that, I used to do this all the time for tibial plateau fractures too. I would have the plates, I would have the screw configurations, I would have the order, fix the coronal fragment on the tubercle first, then we're going to go to the back, we're going to use the upside down ankle metaplate, and we're going to, buttress it here. I need this exposure, I need this clamp, and I need that clamp, then we're going to come to the front, then I need the distractor, I only need a lateral, I don't need a medial. Like all those things, you have to plan it out. I used to take the CT, and do 3D reconstruction on where all the screws would go. And if you have it all planned out and you have your strategy, regardless of what you're doing, distal femur, anything that's complicated, a talus fracture, a pilon fracture, anything that's going to require multiple things and steps, write it down with your team. It takes maximum 5 minutes. And it's the best, even 10, it's the best 10 minutes you'll spend when you're doing 3, 4, 6, or 8 hours of surgery. Trust me.
Excellent.
This is great. Thank you, Dr. Levy. I was wondering if you could tell us how you change your approach to clearing the soft tissue from the tibial tunnel aperture and PCL when you know there's a graft nearby that you're trying to dodge. Because I feel like at the knee dislocation study course, I was struck that some people said, use the shaver until the very last minute, then use the cautery.
Yeah, no.
And some people said, do you just
I'm going to show you, Jackie, on the PCL talk,
yeah,
how I do it. where I
Okay.
use the shaver and when I transfer to the radio frequency device.
All right.
In that case, I did the radio frequency device almost to the bottom, and then I took a freer elevator.
Okay.
Okay. And I just literally felt my hand, because even the RF device, I was worried it may get somewhere. But as a general rule, it's shaver for the bulk at the beginning and then RF all the way down. And I'll show you, I have a nice little video
Oh, great.
that will demonstrate that. And there's a little paper I wrote in core on technical pearls for PCL socket preparation. And it goes like, it has a step-by-step approach. Okay.
Great.
So
Thank you.
with the video I show you, which I could send you, and the core paper, you'll have everything you need.
Okay. Thank you.
Well, that was excellent. Thank you again.